This is Mary Hart, Director of Development for Allergy and Asthma Network, and it's my pleasure to welcome you to this month's webinar in our 2019 webinar series titled Advances in Allergy and Asthma, brought to you in partnership with the American College of Allergy, Asthma, and Immunology. Our webinar series helps Allergy and Asthma Network live out our mission, and that mission is to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. Dr. Don A. Bukstein joins us today, and he will be sharing thoughts with us on allergic disease and drug interaction causing disordered breathing and sleep issues. Dr. Bukstein is a board-certified allergist immunologist, pediatric pulmonologist, and former director of allergy and asthma research at the Dean Clinic in Madison, Wisconsin. He holds hospital staff appointments at multiple health centers in both Milwaukee and Madison. Dr. Bukstein was also an assistant clinical professor in the Department of Pediatrics and clinical professor of family practice at the University of Wisconsin-Madison for over 30 years. He worked as a pediatric intensive care physician for 17 years at St. Mary's Hospital Medical Center. Dr. Bukstein is also a fellow of American Academy of Allergy, Asthma, and Immunology, American College of Allergy, Asthma, and Immunology, and American Thoracic Society. He currently volunteers at a Medicaid clinic in inner city Milwaukee and with the Allergy Asthma Network. Dr. Bukstein received his medical degree from the University of Missouri-Columbia. He completed his internship and residency in pediatrics at Children's Medical Center in Dallas, the University of Texas Southwestern Medical School. And he also completed fellowships in allergy immunology at National Jewish Hospital and in pulmonary medicine at the University of Colorado. Dr. Bukstein has ongoing interests in shared decision-making in allergic disease and asthma, problem-based learning, and treatment of the underserved. He has had numerous articles published in such peer-reviewed journals as Pediatrics, American Review of Respiratory Disease, the American Journal of Managed Care, Allergy, Pediatrics, Allergy Proceedings, Annals of Allergy, and Journal of Clinical Outcomes Management. He is the vice president of the PBL Institute and has helped train over 1,500 physicians in the principles of problem-based learning. As a speaker, he gives approximately 50 presentations each year. Dr. Bukstein, we're grateful that you're with us today, and we look forward to your presentation.
Thank you very much, Mary, and thank you, Sally. Today we have something near and dear to my heart, a discussion of sleep. I want to get through my disclosures here. You can see them. I speak for a number of different companies and, of course, am active with the PBL Institute in teaching doctors better ways to interactively teach. Today we are going to talk about something near and dear to my heart, near and dear to everyone's heart, and that's sleep. And maybe I'll give you some ideas to give advice to improve your patient's quality of sleep, or if you are a patient, improve your quality of sleep and ability to sleep, and understand how sleep impairment is associated with a lot of allergic diseases, asthma, allergic rhinitis, atopic dermatitis, and really has a significant effect on the ability of a patient not only to get enough sleep, but to function adequately during the day. We'll list some of therapeutic interventions and talk about that a bit, and then describe how changes in sleep hygiene and the environment you sleep in can really improve your sleep and sleep quality. I mean, people have been interested about sleep for a long time, and allergic disease is really, and asthma, it really can affect our quality of sleep and can lead to other problems such as anxiety, depression, attention deficit. These are problems that maybe underlying, the patient has them already, but certainly sleep can make them much, much worse. Like I said, we're all interested in sleep. Especially that we take care of allergy and asthma patients. There's 60 million people with allergic rhinitis. There are 25 million people with asthma. And when you combine all these diseases, you can see that if anywhere from 30 to 50% of our patients have some influence of their allergic disease, whether it be asthma, atopic dermatitis, allergic rhinitis, then it's going to affect a huge number of patients potentially. Like I said, we've been interested in sleep biblically. I think it comes from the Old Testament, the lion and lamb shall lie down together, but in this case, the lamb won't get much sleep. But, you know, and I know that I always tell people, laugh and the world laughs with you, but snore and you sleep alone. So we're going to talk a little bit about snoring and sleep. And I know some of my patients that are enrolled in sleep studies, you know, at our institution, really think, and at our office, we have an office in our sleep lab. They call it their dream job. So enough jokes. George Bernard Shaw said that the single biggest problem with communication is the illusion that it occurs. And my good friend Randy Brown said asthma is a disease of communication as much as inflammation. I really don't believe that this is especially true with sleep, and sleep really doesn't get the respect that it needs. It's kind of like the Rodney Dangerfield of diseases. Before we get into how allergic disease affects sleep, I want to just give you some reasons why maybe you can't sleep. If you're like me, you're an older individual, you know, it's true that in fact we get less quality sleep when we get older. We tend to fall asleep okay, but then we get up and have insomnia and can't go back to sleep. There are lots of reasons for this. And before we get into how allergic disease affects sleep, I want to go through sleep hygiene. I'm going to say this over and over again. Listen, if your sleep hygiene isn't good, no matter how well you control your allergic disease, you're still not going to be able to sleep all that well. So there's some things in our society that you need to avoid. Number one on the list I put is blue light sleep. Blue light from our computers and our TVs really suppress melatonin. And we need melatonin. Melatonin is that sleep hormone. Good sleep produces more melatonin, more growth hormone. All those things have a tendency to decrease inflammation, and that's going to be important in a few minutes when we talk about the effects of allergic disease on sleep. But all of us, if we have blue light right before we go to bed, not going to be good. We can wear special glasses to block that blue light, but I think just avoid LEDs and blue light for an hour or two before you go to sleep is not a bad idea. As we get older, we get post-menopause, kind of menopausal insomnia with decreased estrogen. You can get hot flashes, sweaty wake-ups, and you're shifting from in progesterone and estrogen, and you get a warmer body temperature, and the body really needs to cool down for deeper sleep. Hidden caffeine. We all metabolize caffeine a little bit differently, so really try to prevent that cup of tea right before you go to bed that has caffeine in it, or anything that has caffeine. Also, you really need to get a routine bedtime. Many of us that are retired or semi-retired don't have a real schedule we have to adhere to, so we tend to have erratic bedtimes. Not good. Routine bedtime, routine time you wake up is a good idea for better sleep. Nap. You may take naps. They may not be intentional sometimes. Just watching, and I appreciate everyone coming in today and attending this little webinar and missing an hour of the NCAA tournament, but I'm sure there'll be enough games for the rest of the week to satisfy everyone, even those of you in North Carolina. And also bed confusion, I call it. I tend to suggest people not read in bed. when they get into bed, that's associated with sleep, not watching TV or reading. So really reading in a chair, maybe near the bed or in another room, not a bad idea before you go to sleep. No alcohol or wine. They may help you get to sleep, but the sleep is going to be fragmented and you're going to wake up at 3 a.m. and can't get back to sleep. Anxiety. If we're anxious, that's going to affect our sleep. It's interesting, there's cognitive behavior therapies for insomnia and some apps that are online that have actually been studied and aren't bad. I tend to have people write down the things that might make them anxious before they go to bed, maybe talk to their spouse or whoever about them, and they get them off their mind. Then bedroom-based, and that means don't force sleep out of boredom. If you're bored, don't just go to bed if you're not tired. Prescription medications can also affect us, and the poor timing of medications. If you have a diuretic and you're an older individual like me, probably not a good idea to take it right at bedtime because you're going to just exacerbate your getting up a few times anyway for that potentially enlarged prostate or the fact that you're needing to get up. And if you take a diuretic, it's just going to make it worse. So there are other medicines like that, that the timing you take the medication may be instrumental to you getting poor sleep. So now we're going to talk about asthma, allergic rhinitis, and atopic dermatitis, other allergic disease that can contribute and how they contribute to poor sleep. I'm going to tell you one thing before we can talk about poor sleep or disorganized sleep or disruptive sleep or inadequate sleep. We have to recognize that that's occurred. Our most important sleep problem when we see patients with asthma, allergic rhinitis, etc., is to diagnose or at least suspect in many patients whether they have obstructive sleep apnea. There are many surveys that you can use, and it really depends, these questionnaires or surveys, it really depends on where you are in practice, what kind of patient population you have, which one you choose. We like one called Stop Bang Questionnaire. It's kind of an interesting questionnaire. The stop is for snoring, tired, observe, and pressure. And you just ask yes or no to these questions. Do you snore loudly? How often do you feel tired, fatigued, or sleepy? Has anyone observed you stop breathing? And are you being treated for high blood pressure? These will give us an idea, along with what we call the bang, which we get from examining the patient. Are they obese? Do they have a massive BMI of over 35? Are they older, over 50? Do they have a large neck size, over 17 for males? And are they a male? If they answer positively to the stop and the bang part of this question, bingo, we need to do more to investigate probable upper airway obstruction. But sleep problems, and this is kind of the grading system we use, sleep problems aren't just in adults, they're in children too. And depression, anxiety, stress can really, and then even attention deficit or hyperactivity types of syndromes can coexist with asthma and allergic disease and be made much worse by inadequate sleep. We use an instrument to really discover this it's called BEARS. It's divided into 5 major sleep domains, and it gives us, for the 2 to 18-year-old range, it gives us a good idea of what their sleep is like. And BEARS stands for bedtime problems, excessive daytime sleepiness, awakenings during the night, regularity and duration of sleep, and snoring. And you can see here the kind of questions depending on whether they're a toddler, school age, or adolescent. For an adolescent, we may say, do you have any problems falling asleep? Do you sleep a lot during the day or at school or while driving? Do you get tired? Do you wake up at night having trouble getting back to sleep? That's the awakenings. Regularity, what do you usually when do you go to bed? And do you do the same time on weekends? And then the snoring, do you snore loudly? And so it's important to recognize upper airway obstruction or the possibility of upper airway obstruction by doing some sort of screen on almost all our patients, because obesity lends itself to upper airway obstruction, and these are two of the most important comorbidities we see in asthma and other allergic diseases. The other thing is that I want to impress upon you how different age groups, you kind of have to ask different questions. And that's why we like the Bears kind of questionnaire. Other questionnaires like the Epworth and other Pittsburgh sleep questionnaires are very good, and it depends on your patient population and where you sit, whether you're in a big medical center or in private practice, which questionnaire lends itself to your practice. Allergic rhinitis will start with the top in allergic disease and asthma. In allergic rhinitis, there are a lot of comorbidities, and almost all of them can give you problems with sleep or be a result of sleep disruptions and problems with sleep. So you can see some of the associated and comorbid conditions associated with allergic rhinitis. But really, in allergic rhinitis, quality of life and ability to function during the day has a lot to do with sleep. So does psychomotor functioning, and decision making, and emotional factors, poor self-image, especially in teenagers, the ability to perform daily activity in school and work absenteeism. And I think the most alarming thing, these things can occur because of poor sleep, and the patient may not have subjective feelings of sedation or tiredness, but have these problems that they encounter on a daily basis. Sedating antihistamines just add to the problem. When patients are symptomatic, in children, they're often described, allergic patients with allergic rhinitis and or asthma, as inattentive, absent-minded, irritable, preoccupied, having impaired learning, poor school performance, be a underachiever, disruptive. They may be misdiagnosed, again, as I said before, with ADHD. In adults, same sort of thing. They may be the inattentive worker, absent-minded, irritable, preoccupied, clumsy, kind of the seven dwarfs. I'm a happy, sometimes bashful doc, but I'll tell you, if I don't get sleep, I'm sleepy and grumpy and moody and whatever the other dwarfs are. It really can affect your day-to-day functioning in both adults and in children. There have been big surveys, the nasal NASL survey of over 400, and then the AIA, Allergies in American survey of over 2,500, and they give us the same result. Patients really say they're irritable. A good number say they're depressed, tired, embarrassed, miserable, but that irritability is a marked indicator of possible sleep problems. So how do you tell if somebody's having a problem during sleep? Well, you can use the questionnaires, or you can ask, are they snoring loudly? As I said, if you're snoring, you're going to probably sleep alone a good bit of the time. So observed apneic episodes, you stop breathing, snorting, gasping, restless sleep, sweating during sleep, enuresis, getting up or going, for kids, not being able to control it, their bladder and having increasing enuresis at night, or bedwetting. Daytime symptoms, tired, school problems, morning headaches, nasal congestion, mouth breathing. A common problem with significant upper airway obstruction in kids and adults is that morning headache, that congestion, mouth breathing, dry mouth because you can't breathe through your nose and maybe obstructing during the night. Also, I want to point out something here. My receptionists have always had a checklist. If you go on the Allergy Asthma Network's website, you'll see a bunch of checklists and aids to practice that are there for you to use. One of the things I ask them to do, and say if they're coming into me and one of the complaints is poor sleep or tiredness, fatigue, that they do a little minute or two of cell phone video of them sleeping. So their partner or the parent or spouse can do a little taping of them sleeping, and they bring that in for me to look at. That helps tremendously because I can see many of these manifestations that are occurring at night by just looking at that little video. Now, who was able to sleep? This is a survey or study of about 7,000 patients, and they used a sleep problems index scale. I'll show you in a second. But for those patients, less sleep was associated with lower cognition scores and lower productivity. So if you had no symptoms, or you had allergic rhinitis that wasn't a rhinitis, not allergic rhinitis, they were less of a problem than allergic rhinitis with regard to sleep and poor cognition and lower productivity. So if you look at it, the bottom line, if you can't sleep, then you're going to have problems with exercise, concentration, irritability, sexual activity, daily functioning, emotions, ability to cope, staying on task, headaches. Pretty much everything that gives you a good quality of life is affected by sleep. So again, allergic rhinitis adversely affects a lot of people. 12 million people employed in the U.S. suffer from allergic rhinitis, at least. There are probably close to 60 million people that have some form of rhinitis, and 52% symptomatic on work days. There are 3.6 missed work days a year from allergic rhinitis, about 120 hours of presenteeism. That means you're at work, but you have decreased productivity, and the average cost to employers is about $600 a person. So this is an impactful disease pharmacoeconomically. But it's just not the older patient or adult. The kids have the same problem. Lack of sleep, it's irritability, and their underlying allergic rhinitis can precipitate more asthma. They can be very moody, always cold, hoarse, constantly rubbing their eyes, pulling their ears, snotty, and exhibit the dopey and grumpy of the seven dwarfs. And they can have allergic rhinitis can affect their parents' productivity, but for a child, it's all about school and functioning and being able to function at school. And they have a kind of presenteeism too, where it will increase their absenteeism and their ability to produce in school. When we come right down to it, whether it's asthma or allergic rhinitis or atopic dermatitis, it's all about impairment, having no symptoms, no rescue medication, and better sleep and no daytime fatigue. You want normal airflow through the nose or through the lungs, normal looking skin. You want normal activities and not missing work and school and good quality of life. And you don't want exacerbations. And you don't want there to be secondary sleep apnea. Oftentimes with a severe allergic disease, especially asthma, patients will cone down their activities, they'll gain weight, and this is the perfect setting for increasing upper airway obstruction and significant sleep apnea. It's kind of a bell-shaped curve, and we'll talk about sleep apnea now in a minute, but you start maybe with allergic rhinitis, gain weight, and don't exercise with more asthma, and then that obesity combined with the allergic rhinitis combined with genetic predisposition, bingo, you've got upper airway obstruction or sleep apnea. And it may start with snoring, and you may get what we call disrupted sleep or upper airway resistant type of syndrome, and that goes into full-bore sleep apnea where you have hypoxic episodes. Here you can see, again, proving the point that the relationship between sleep efficiency, you see here, and quality of life and your cognitive performance. You can see that quite nicely. There's a nice study about sleep disturbance and asthma control. It's kind of a real life study. You can see here the 5-step sleep questionnaire. Question 1, do you have difficulty falling asleep? Do you wake up at night? Are you tired during the day? Do you have difficulty concentrating? Do you feel nervous? And they compared that to the ACT test. And you can see here quite nicely that if an ACT test is abnormal, here in red, less than 20, that you have a much higher rate of answering those questions positively, that you have significant sleep disruption. So again, sleep disturbances has an impact on your asthma. So the association now with obstructive sleep apnea risk and control. The aim of this study was to see if there is really a high incidence of obstructive sleep apnea risk associated with not well-controlled asthma, and they did the asthma control questionnaire like the ACT, the sleep disorder questionnaire to get sleep, and you can see quite nicely that, in fact, in this study, that these patients, their obesity, their gastroesophageal reflux, their nasal disease, and even some psychiatric symptoms were really in many ways related to their high incidence and high risk of obstructive sleep apnea. So obstructive sleep apnea is not only a potential, but a real contributor to poorer asthma control. And if you have asthma, okay, and you're getting lots of inflammatory mediators being released, also not producing as much melatonin, that can really be exacerbate, okay, any underlying allergic disease. And you can see here how nasal obstruction and the balance between wakefulness and sleep arousal, how you can have a mediator, histamine, that affects those. Here you have cystoleucotrienes, increasing slow wave sleep, increasing disordered breathing and nasal obstruction. You have IL-1, IL-4, IL-10 affecting sleep latency and REM sleep. You even have bradykinin that's increasing nasal obstruction and substance P. So there's this interrelationship between sleep and allergic disease, and one can affect the other. If you have upper airway obstruction, and you can have a whole host of related problems, whether it's asthma, which we talked about, or reflux, which we talked about, or cardiac functioning. You're not going to be able to lose weight easily because you'll be suppressing that leptin secretion. You're increasing leptin secretion, you can suppress it by treatment. And certainly if you want to lose weight, if you're having upper airway obstruction and poor sleep, makes it very, very difficult. So really, treatment with CPAP or positive pressure for upper airway obstruction is very beneficial to a number of organ systems. Now, treating sleep, and especially upper airway obstruction, can affect, since upper airway obstruction and sleep apnea can affect diabetes, stroke, heart disease, hypertension, and mental health. You can imagine it has a huge economic cost, well over $30 billion a year. So it also has a lost productivity cost, which is even more, as much, some estimates are today, because of the increase in obesity and sleep problems and upper airway obstruction, almost $100 billion. In this study, it was $86 billion. So again, cost savings can be huge. Absenteeism, presenteeism, behavioral problems, poor decision-making in the workplace, all can be improved by diagnosing and treating upper airway obstruction or sleep apnea in patients. And it's not only important for patients, improving their health and productivity and quality of life, but for payers and employers. And the same goes true with treating more milder forms of sleep disruption from underlying asthma and allergic disease. So again, if you have improvement in the quality of sleep, this will obviously be a perceived benefit of treatment. It can improve the patients and the quality of life and their mood, and have a relationship with their bed partner. And again, you can see the areas of high influence, lower influence, but certainly very high influence in sleep improvement being a perceived benefit, and having moderate benefits in improving patience, improving quality of life and mood. So one of the things that happens when we have uncontrolled allergic disease, asthma, allergic rhinitis, atopic dermatitis, can lead to depression. There's no question depression has a lot to do with problematic sleep. And we see depression very commonly in poorly controlled allergic diseases. For the last 2 or 3 decades, we've been trying to do screening of depression. The 2-question screening that we use is quite simple. During the past month, have you been feeling down, depressed, or hopeless? During the past month, have you been bothered by a decrease in your interest and pleasure of normal activities? If either one of these are positive, then we administer what we call the PHQ-9, which is a more 9 questions that is a screen for depression. We find extraordinarily high incidence of depression, especially in our asthmatic, allergic rhinitic, atopic dermatitis patients that are having poor sleep. This is where your staff can really help you. Asthma educator, medical office staff are a good first step to talk about these concerns. They can help make the diagnosis of poor sleep by using one of these sleep questionnaires. They can make sure there are no other contributing factors, medication factors, that sort of thing. The pharmacist is a big help here too. They can discuss the availability of treatments we'll talk about in a minute. If appropriate, they can work with the patient to draw up a kind of mental health plan. If there's anxiety, depression, other things, they can work with the psychologist or refer to a psychologist for ongoing treatment. They can provide brief counseling in some cases, and can get that person to a healthcare specialist like a psychologist or social worker that can really help with those problems. Also helpful strategies that you can get right at Allergy and Asthma Network can help you learn more about asthma and how to take better care of asthma and allergic disease. Learn how anxiety, depression, and all these and asthma interact with each other. And by controlling your underlying asthma, you can decrease that anxiety and depression. Learn how to distinguish the symptoms of asthma from the symptoms of anxiety and depression. Oftentimes, they can get confused, and both can cause poor sleep. And poor sleep, these problems are made worse by poor sleep. You can plan with your doctor not to have just a written action plan, but a lifestyle plan that includes better sleep. That doctor regularly, and you can use the asthma medication as prescribed. Good adherence, taking that medication twice a day instead of once a day, as your doctor instructs, is really, really important. Get down the barriers to taking the medication, such as cost, organization, planning, ability to get to the office, the availability of samples, and ways, more creative ways to pay for medication. You can get encouragement from family, friends, and support from them, and really help with some of the problems that we see with sleep. It may start with snoring, choking, gasping, restless sleep, but it may go into witnessed apneas or cessation of breathing for 20, 30 seconds sometimes, frequent awakenings, excessive sweating, and sleeping in unusual positions. If you see these symptoms, you really need to get a physician involved and think about screening for sleep apnea. We now have wonderful sleep apnea tests that you can do at home instead of in a sleep lab in the hospital initially. And many times a home study gives you all the information you need to get the patient on treatment, positive pressure or CPAP. Also, with sleep and obstructive sleep apnea, you see those, and with sleep disruption caused by allergic disease, you see the behavior problems, the hyperactivity, the daytime somnolence, and in kids, you'll see aggressive behavior, rebellion, maybe shyness, withdrawal, and some cognitive abnormalities. Predisposing factors we see in kids all the time are big tonsils and adenoids, obesity, but rarely craniofacial problems, small face or micrognathia, all can be issues. And there are certain diseases that we know, obesity being most common, where sleep apnea is more common. So again, who should be treated? Well, years ago, a well-known pulmonologist, Dr. Gillette, said children with soft intermittent snoring, but without obstructive sleep apnea and without other signs of sleep problems don't need to be evaluated. So just snoring a little bit intermittently. But children that have loud, continuous breathing difficulties where they gasp, large tonsils and adenoids, really need to be referred to ear, nose, and throat for, now we can do good at-home sleep studies or in-house sleep studies to make a diagnosis to see if they need surgery or some other intervention. I think you should do a video at home, bring it in, and that helps me and other pediatric pulmonologists really determine, is it just a little sleep disruption because you have asthma or allergic rhinitis or atopic dermatitis, or has it evolved into significant sleep apnea? Now, we all sleep usually in the bedroom, so making one space in your house at least as allergen-free as you can isn't a bad idea. Although we don't have undisputable evidence that pillow covers, mattress covers that are encased in plastic help, I think if you have severe dust mite or other allergen sensitivities, this may help. Wash the blanket sheets, pillowcases in hot water, vacuum once a week. You can use the HEPA filter on that. You should keep your kid out of the bedroom when you're doing all this cleaning and wiping the surfaces with a damp cloth every week or two. And clean exposed floors. That hardwood floor is best for the kid with a throw rug that you can wash. You can use air purifiers, humidifiers if necessary, or vaporizers if necessary. But oftentimes, the main thing is getting a lot of those stuffed animals out, washing them in hot water, and making sure the bedding is adequate. If you want to evaluate upper airway obstruction and sleep problems in kids, you can do that overnight. Little 2-3 minute recording for your doctor to see. You can do overnight pulse oximetry, looking at oxygen saturation. But one of the new devices that you're going to see, if any of you have a Fitbit, you're going to see the ability to judge disruptive sleep by just looking at information of how the patient moved, how often they moved, what their heart rate was during sleep. So we're going to have better and better ways of assessing sleep objectively in the future. But if you're concerned, you need to order a polysomnogram, which really gets either in the hospital or in a sleep center, or more typically now at home, gets at this disordered breathing. Again, pediatric obstructive sleep apnea we talked about in some detail. So keep your humidity at the right level. In the middle of allergy season, a shower before you go to bed. And you want to try and reduce strong smells. Some people like to burn or put in fragrances they think help them sleep. Probably not a great idea for the typical allergic asthmatic patient. You want to avoid tobacco, candle, incense, avoid feather pillows, down comforters. Avoid eating in the bedroom because that just attracts cockroaches and is just going to be food for all the bugs and things that may creep in your bedroom. So no eating in the bedroom. Pets should stay out of the bedroom if you have a child who's allergic to the pet, and replace all the pillows. We try to replace them. I tell them every 3 years if possible, and keep that humidity below 50%. Clutter-free rooms are really kind of essential here. And in summary, what can we do? Well, in summary, both poor sleep and obstructive sleep apnea and allergic rhinitis, we can really diagnose it a lot better. We can seek help. We can use people in our office. We can know its relationship to anxiety and depression and even ADHD, and support accountability in the patient. We can do some sleep hygiene. Remember, I told you at the beginning that sleep hygiene has to be the first thing that's done, along with trying to control the environment as much as possible. Limit alcohol. It's a stimulant and a depressant. Nicotine is a stimulant. Don't nap after 3. Get 20 to 30 minutes at least of exercise a day. Don't do it right before you go to bed, though. You really concentrate on that mattress, pillows, and bedding. You want a comfortable room temperature. Believe it or not, it's been pretty cold here in Wisconsin over the winter, but a cold bedroom is not bad. It really lowering that body temperature initially promotes sleep. You don't want it too cold. Avoid non-sleeping activities in bed, like watching TV, bill paying, and doing paperwork. And keep light and outside noises to a minimum. Try not to look at that TV right before you go to bed. Maybe some soft music or white noise from one of these contraptions that make it sound like the ocean's next to you. Ventilation it needs to be good. Humidifier, you want that humidity just right, not too high or not too low. Air purifiers may help depending on the allergen. One of the things that I stress to my patients is proper breathing. There's the 4-7-8 kind of breathing I'll talk about in a second. You can talk about meditation a little bit, visualization. I tend to tell my patients to write down the things you can't get out of your head before you go to sleep, make a list and say, I'm going to deal with these in the morning. And sometimes that helps a little bit. But it's really about lack of sleep hygiene, lack of schedule, lack of exercise. That produces lack of melatonin, and that produces lack of relaxation. And we don't breathe properly, and we eat right before we go to bed. All those things really put us at a disadvantage. And with breathing, I tell my patients a simple breathing technique is to exhale with a whoosh out your mouth, then inhale quietly through your nose for a count of 4 seconds, hold your breath for 7 seconds, and then exhale through your mouth audibly with that whoosh sound over 8 seconds. If you practice that every day, it's kind of like how do you get to Carnegie Hall? You practice, practice, practice. Well, if you practice this 3 or 4 times a day, you can do it if you can't get back to sleep. And a lot of times that will promote relaxation and your ability to get to sleep or get back to sleep. In the end, what we talked about today, to sum it up, is that there are certain anatomic, biologic, pathophysiologic factors, such as being laid down in the supine or prone position, that encourage inflammatory mediators. And these are more present in allergic individuals with allergic rhinitis, asthma. Environmental factors such as allergens or irritants can affect the environment. Individual factors such as adherence to medication, their sleep hygiene, sleep behaviors affected. Cultural factors. We know in areas of underserved, multiple medical problems, many individuals sleeping in the same room can have effect on sleep. Allergic disease, we talked about. Sleep, the timing and quality, and if there's disruptions. And all these things end up affecting the disease activity and ultimately the outcomes. So disease, inflammation, and sleep are linked. They have this complex relationship where they can each make each other worse. And likewise, if you improve one, you're very possibly going to improve the other. Treatments of asthma, allergic rhinitis, and atopic dermatitis really show an interaction between sleep and this disease. And by improving sleep and improving the disease, and not forgetting sleep hygiene, we can go a long way to improving our outcomes, our quality of life, and ultimately what we all want to do is get a good night's sleep. So I hope that all your sleep is good sleep, and like many of my patients say, you have a dream job when you are thinking about sleep and getting everything ready for a good night's sleep. So we have time for questions, I think.
Yes, thank you, Dr. Bukstein. We'll take questions now. In fact, I have received a question. What is your recommendation, Dr. Bukstein, about when a patient is finding that their doctor is reluctant to test their sleep issue?
I'm sorry, repeat the last part of that. I didn't.
When the physician, when their doctor is reluctant to address or to test their sleep issues?
Well, first of all, I don't think we spend about half of our lives, a good part of our lives, at least 30 to 40% of our lives sleeping. So that's a good part of our existence. I think you can go a long way by looking up these questionnaires online. And I've had several patients that have consulted Dr. Google in this respect and come in with the questionnaire, whether it's the Epworth or another or depression screen, and say, listen, I filled this online and I'm having sleep apnea. I'm having depression. Likewise, always a second opinion. Usually it's a pulmonologist and ENT doctors dealing with upper airway obstruction if they're snoring and disrupted sleep and a cessation of respirations. When you view that little 30-second to 2 or 3 minute video that the parent can take or the spouse can take of the patient sleeping. I think the first thing you might want to do is just take in a video. And oftentimes disrupted sleep is very evidenced by just a few minutes of a video of the patient sleeping. But I think if a physician doesn't recognize or ask you questions about sleep, it may be time to think about a second opinion.
Thank you. Another question, since the function of kids, or the kids that have allergic rhinitis and have the sleep disturbances, is there a way for the school nurses to evaluate the kids at school? Is there a tool or anything that they could use at the school?
We years ago started a program, this was quite a few years ago, where we'd have the school nurse, and in Madison there was a school nurse, an RN at every grade school. We would have them, especially if the child was obese, use a questionnaire like the Bears. The Bears wasn't available then, but the childhood questionnaire that I put on the screen, the Bears, is a real good one because it's for different ages, a little bit different questions, and that's appropriate for kids. And they would use that as a screen. If that was positive, I would get a referral right away to really untangle why isn't the child sleeping? Why are they snoring? Why are they restless? Is it their asthma's out of control? And we all know that the patient's asthma, well, the nighttime doesn't belong to Michelob, it belongs to asthma. So that asthma gets worse at night, so does allergic rhinitis in the early morning or evening, depending on the allergen exposure. But again, kids are oftentimes overlooked, and especially if the child's obese, he can have a form of obstructive sleep apnea even at an early age. Oftentimes it may be tonsils and adenoids that are enlarged, secondary to their allergic rhinitis. And so it's sometimes a difficult thing to sort out. But I think using the questionnaires for nurses is a good way to start.
Great. And I have one other question here. With all the big hype about salts, lamps, and essential oils, do they play a role in improving sleep for people that have allergy?
Well, it's interesting. There is some work that essential oils for some people relax them. If you relax, you're going to go to sleep easier. Okay, so there is a little bit of data, but again, in asthmatic or allergic patients, these oils oftentimes have strong odors and can actually exacerbate symptomatology. So I would suggest probably not in our population, the allergic, asthmatic, atopic patient. Lights and other things, certainly not having blue light, not having LED lights, can be a positive effect. Some people have a hard time because they don't get natural sunlight during the winter months. Sometimes that may be helpful to reestablish your normal circadian rhythm. There's a very interesting study done out of Boulder, Colorado, where they took people camping who had sleep problems to reset their circadian rhythm, and it really worked. So being outside and kind of doing things by the sunlight and by number of hours of light rather than time seemed to reset their circadian rhythms and was a positive effect. So you know, we're kind of complicated organisms, and anytime we tend to go away from our normal rhythms, that's why it's so important to establish, even when you're retired or off for summer vacation, a constant time that you go to bed and a pretty much routine time that you wake up on a daily basis. And we need about 8 hours sleep when we're 30, and we need about 7 or 8 hours sleep when we're 70. And it's important to try and figure out how to get that the best way possible.
Okay, we've got time probably for one more question, and it has to do with shift workers. What advice do you give to people that work maybe night shift one week and then second shift the next week?
There's been a lot, there's been a lot done with shift workers, and they're really difficult. And sometimes I've treated them with melatonin, 3 to 5 milligrams of melatonin. Oftentimes it's all you need, and maybe sometimes a little bit more when they need to go to sleep. But that's a huge problem. And if you're a shift worker and you haven't gotten into a schedule or have a completely erratic schedule, then maybe spending a little time to go to a sleep specialist is worthwhile, and usually easily paid for by whatever company you're working for, because this is a problem that's been well delineated. And there are some other things you can do for it, but those patients have a more difficult time, and I think under a physician or sleep expert's kind of recommendation is the best way to go there.
Thank you. And thank you all for listening today. There was a couple of questions too about the slides. We do not share the slides, but if you would like to hear this presentation again, you can go to our website and hear it again. Also, at this time, please download the handouts from your control panel. If you have any difficulties, you can email us using the link in your emails. Please join us next month for our April webinar with Dr. Maeve O'Connor. She'll present on microbiomes and allergy and immunology. And this webinar will air on Thursday, April the 25th at 4 p.m. Eastern Standard Time. You can register for this webinar on our website at allergyasthmanetwork.org. Look for education in the horizontal navigational bar near the top of the page and scroll to webinars. You can also view our archived webinars on this page on our website. Visit our website for quality guidelines-based resources on allergy and asthma. Also, access important medical information on allergies and asthma from our partners, the American College of Allergy, Asthma, and Immunology at allergyandasthmarelief.org. Thank you again for joining us, and we will look forward to having you registered to be with us next time on Advances in Allergy and Asthma. This is Mary Hart for the staff of Allergy and Asthma Network. We hope you have a great and healthy day as we work to breathe better together.